along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello, good evening, everyone, and welcome to a special edition of our Caribbean African Targeted Health Improvement Program, CATHIP. So CATHIP is brought to you by a couple of partners. So we've got the Caribbean African Health Network, RAFA International Development Trust, a Croydon BME Forum, Enfield Caribbean Association, Black Health Initiative in Leeds, and then the RCCG Royal House from Sheffield. This very evening, we are excited to have a very renowned speaker. He's not, a stranger to us, but he's been working incredibly hard all day. He's just finished a diabetes clinic. So we're really grateful for your time, Dr. Abiye Hector Goma. So this evening, he will be, taking us through irritable bowel syndrome as well as bowel cancer. This has been in the news recently, and I will leave Dr. Abiye Hector Goma to do justice to the topic. Once again, make sure you share the links with your family and friends. We also live streaming on Facebook and YouTube, so make sure you join. And in the course of the discussions, please feel free to use the chat box, but also let us know where you're joining us from. And, my colleagues will be having chats and conversations in the chat box. After Doctor's presentation, he'll be taking questions because we want you to leave very much informed. So Dr. Hector Goma, massive thanks for your time, and over to you.
Thank you very much, Charles. I'm delighted and highly privileged and honored to be here with you again. Thanks for inviting me. So we're looking at IBS, Irritable Bowel Syndrome, and we'll touch on bowel cancer also. As Charles said, the latter is quite a topical one. Let's get on then. So one of the reasons why I have interest in IBS per se is that it is one of those conditions where patients have to take charge of the condition. Some conditions like that acute appendicitis, you were seen in A&E, the doctor takes charge and then takes to the theater, or a woman has obstructed labor, she needs cesarean section, is the doctor that's in charge. But some conditions, long-term conditions like IBS, patient has to be in charge, and that's one of the reasons why I like talking about IBS. So this evening, we'll answer a few questions. What is IBS? How common is it? What causes IBS? How do you know you have it? Can you cure it? What else should I know about it? What about bowel cancer? And what action points would I leave us with? So IBS, Irritable Bowel Syndrome, is a chronic condition which is characterized by abdominal pain or discomfort. And there are symptoms that have to do with movement of the bowel. So it's classified as IBS-C, which is Irritable Bowel Syndrome. C stands for constipation. So apart from pain or discomfort of the abdomen, the second symptom is constipation. Then there's IBS-D. The opposite of constipation is diarrhea. So some patients have diarrhea. Four key symptoms of the of IBS: pain or discomfort, constipation, diarrhea, or some have mixed symptoms. And one of the key features is that if people have pain in IBS, many times when they open their bowels, the pain gets a lot better. So the pain is often relieved by defecation. And some have bloating of the abdomen. Some patients will tell you, I feel like I have 9 months pregnant. And the key point here to remember is that there are no structural abnormalities. And that's why it's called a problem of the function of the gut. It's, if, for example, if you had an abscess, the place is swollen, but generally there is no structural abnormality. Most tests will come to that. When you do those tests, you don't really find anything in IBS. So how common is it? In the UK, it's about 17% of the population have IBS. It's slightly more common in women, about just a bit about more than 1 in 5 women have IBS. Interestingly, in America, when you look at gastroenterologists, those who specialize in matters of the gut, almost half of the patients who have problems of the gut, who are referred to them, have IBS. That's just to show how much IBS is common in the environment. Now, interesting that after so many years of medical research, we still don't know what the cause of IBS is. A lot of research is ongoing. There are many postulations, but it's suggested that there is not just one cause of IBS, it is multifactorial. Of course, the obvious one is that there's something wrong with the movement of the gut. There's a problem with motility. Just to mention here that there are two main nervous, the nervous system, the two main parts of the nervous system have an effect on the movement of the gut. So if the gut is moving very quickly, it means there's not enough time for the body to reabsorb leak water from the gut. And when that happens, we tend to have loose stool or diarrhea. If the gut movement is very slow, the body has all the time in the world to remove water from the gut. And with that slow movement, the stool becomes hard. So you have constipation. Another cause of IBS is the inflammation of the walls of the gut, the lining of the gut. So if you look at this drawing here, if I can get a pointer. So you can see this is like a cut section of the gut. So if you look at the lining of the gut, you find out that the lining of the gut is inflamed. And I just put this diagram here just to give us an idea of what we have here. You have the lining of the gut, and then you have the muscle layer, and then you have the nerves, you have the arteries and the veins. So all this working together can either cause constipation or diarrhea. So there may be inflammation of the gut. So people who have had kind of infections, whether bacterial infection or parasitic infections, that can be what triggers IBS in some patients. And there is evidence that it runs in families. So sometimes if you find a parent that has IBS, you might find out that the child has IBS. In fact, I suffer from a form of IBS, and I realized that my eldest daughter also struggles sometimes with the IBS type symptoms. And she will look at me when she's having abdominal pain and say, "Dad, it's your fault." And we have a little laugh about it. So there is the immune system that also can have something to do with IBS. And this is also important, psychological factors. People who have a lot of stress, maybe exam stress or work stress, family stress, emotional tensions. And then it's also very important to note that people who have either been physically or sexually abused, almost more than a third of them have symptoms of IBS later on. And that's a kind of an important thing for us as clinicians. If people come to us with IBS symptoms, it's always important that we ask about abuse in their lives, because this may have happened and they've not told anybody. So history of abuse in a child, a man, a woman can present with IBS symptoms. And then there's a dietary component. Some people have IBS when they eat particular foods. And then a lot more research is showing that the good germs which live in the bowel, sometimes these germs have an effect on the carbohydrate that we eat. And this effect of the carbohydrate leads to overgrowth of some bacteria or leads to stimulation of the intestines and give about IBS symptoms. That's something. So these are kind of the causes. Don't worry about this diagram, but it's something I just thought I should share. This is the lining of the intestines, and these here are the different types of bacteria which live in the intestine. And if the percentage of each of these bacteria, if there's a predominance of one, like the red type of bacteria in this diagram, that leads to passage of some chemicals from the wall of the intestines inwards, and this leads to reactions, and then some more chemicals are produced which irritate the nerves, and various things happen. While on this side, you don't have all of this happening and the nerves are not stimulated. So when the nerves are stimulated, things happen, and then the symptoms of bloating or diarrhea or constipation can take place in the individual. So this kind of looking at what exactly happens at the level of the cells. This again says something similar. And I've just talked about this, that IBS, the experts go to Rome once every couple of years, and then they look at IBS. And these are the 4 classifications: IBS-C, IBS-D, IBS mix, and then the 4th one is unspecified IBS. So what's the history? When people come to us, and have these symptoms we mentioned, when we ask, sometimes people may remember that when IBS symptoms started, it was after they had an infection, maybe some bacterial infection in their gut. A few weeks after it had cleared, they began to have these symptoms of IBS. And as I mentioned earlier, stress at home or stress at work could bring about people having IBS, physical or sexual abuse. And then diet also plays an important part. Fructose-containing food, alcohol, caffeine, cow's milk, for some people can cause IBS type symptoms. And this is important. Many of us have chaotic lifestyles. Some people have regular time, they eat their food at regular times. Other people eat food in the morning, sometimes late in the night. It's very chaotic. So irregular or inadequate meals can trigger IBS. Insufficient fluid intake and even excessive fiber intake, in the sense that you have 2 kinds of fibers. You have soluble fibers and insoluble fibers. And for some people, taking a lot of insoluble fibers can be a trigger for them coming down with IBS. So what else do we need to know? We'll talk about this again, that people that have a family history of inflammatory bowel disease or colorectal cancer, which we'll talk about later in this presentation, as well as celiac disease, these 3 conditions have similar symptoms as IBS. And the million-dollar question is, how do you know it's not one of these, but IBS? So it's mentioned here that IBS is a functional disorder. Every test you do in IBS comes back normal. There is no test to make a diagnosis of IBS. So when we do tests in IBS patients, we are trying to rule out other possible causes of IBS and not to confirm the diagnosis. There is nothing, everything comes back normal. So when we've done various tests, and we say all your tests have come back normal, then we can say the patient has IBS. So in making a diagnosis, the diagnosis is almost always based on the history of the patient. So the patient has maybe recurrent abdominal pain or discomfort. On the average, once a week at least over the last 3 months. There are patients that have had these symptoms for 3 years, 5 years, but apart from these symptoms, they are very well in their self. Everything is fine. And that's the interesting thing about IBS. You would have had these symptoms for many weeks, many months, many years, but you're otherwise fine. You've not lost weight. Everything is fine. So it's more or less a nuisance more than anything else. So to make a diagnosis, you will have had at least once a week, you have the symptoms of pain, diarrhea, or constipation. And many times the pain gets better after the person has opened his or her bowel. There is change in the frequency of the stool, and there's also change in the form of the stool. You have people that will give a history, such as in the morning I wake up, I get ready for work, I pick my bag. When I get to the door, I have to just drop my bag and dash to the toilet. And once I finish, I'm fine for the rest of the day. And that kind of thing happens with some people when they get to work. So you find that there's always something to do with either defecation or abdominal discomfort or bloating. Those are the key symptoms that people have. So how do you manage or how do you treat IBS? Based on what I've said so far about the causes, the most important thing in IBS management is lifestyle. Some people have IBS-C, which is a constipation version of IBS, and they are quite sedentary. So increasing physical activity is a key aspect for those who are sedentary. And we, of course, this same message of physical activity cuts across every long-term condition you can think about. The next one is food diary. Some people, when they come and see us, they give a history of food. They eat something, and then they get bloated, they eat something, and then they have diarrhea. So we always say, do a food diary for 1 week. You may realize that, let's see, I'm from Nigeria, I like to eat eba. And let's say I eat eba and vegetable soup today, and I feel I've had IBS type symptom. I can make a note of it. Maybe in 4 days' time, I eat eba and vegetable soup again, I'm fine. So generally, it is not just having a symptom once. If every time you eat that particular food, you have the symptom, then you can link that food to IBS. And you hear patients say something like, oh, I like my pizza. When I eat my pizza, my tummy is bloated for the next 6 hours. That's fine. I'm not going to stop my pizza. So it's good to keep a food diary and then just to see if there's any consistent link between the food you eat and the symptoms of IBS. The other one is time management. People who are stressed at home, at work, have poor time management. This can have an effect on the movement of the gut. So improving our time management, having adequate sleep for adults, 7 to 8 hours every night. I know having a structure to one's sleep, not sleeping 9 p.m. today, 7 p.m. tomorrow, 1 a.m. next day, and all that. So time management, adequate sleep, and those are the kind of lifestyle things that will always have a beneficial effect on IBS management. And then what are natural treatment options? Probiotics, and which are, for example, bacteria and yeast, which have been added to yogurt, may help to restore the good bacteria we have in our gut. And if you try this for 1 to 2 months and there is no improvement, you can discontinue them. So that's something that is quite good to use. And sometimes when people are given antibiotics for one infection or the other, these antibiotics can reduce the good bacteria in the gut. So taking some probiotics sometimes helps to restore the balance. And then peppermint oil is from peppermint plant. It has a calming effect on the intestine. So sometimes we prescribe peppermint oil for those who have either bloating or abdominal pain because it has a calming effect. And it comes from peppermint plant. And then dietary fiber, like I said, to increase soluble fiber, such as oats, such as fibogel, and to decrease insoluble fiber. Bran tends to be insoluble. And for those who have IBS, increasing you taking of Quaker oats or any of those oats as well as fibogel will help to increase their soluble fibers and thereby may reduce the IBS symptoms. And then sometimes if you know one particular food always gives you IBS symptoms, then you may decide to stop taking that food for a while and see if the symptoms disappear. And then there's what is called the FODMAP diet, which is usually done under the supervision of dietitians. FODMAP diet is something that is worth trying. Before I move on, I'll just say that if you Google IBS Network, there's an excellent website. I think they are based in Sheffield, but it's an excellent website. It helps you to look at the various symptoms we've talked about and what you can do to help yourself. And I always tell patients, have a look at that IBS Network website and try and look at some of the things and see how it goes. How do you, beyond what I have said, what else can you do to manage IBS? Research has shown that patients who understand IBS, they read about it, they understand it, they know the 4 main symptoms, and they know what to take for each of those symptoms. When patients take charge of the symptom and they're in control, the IBS is better. There are some patients who have just IBS and they don't take control, they don't take charge. They're always looking up to us as doctors to find a solution to the IBS. They tend to become slaves to the IBS, while those who say, this is my life, I have to take charge, they tend to do better. And that's one of the messages I give to the patients, that don't keep on expecting me to find an answer to IBS. Your lifestyle and depending on what symptoms you have the medication to treat those symptoms. So for example, some people have diarrhea predominant IBS. So it's important for them to have loperamide in their medicine cupboard. Some people have constipation. It's important to have bulk forming laxatives, especially fibrogel, at home. Some people have abdominal pain as the main symptom or discomfort. So they can have paracetamol, antispasmodics like Buscopan, avoid ibuprofen. And then for some people, the IBS is related to stress, all the issues in their lives. So for such people, psychological therapies and medications for anxiety or depression may actually be the answer to improving the IBS symptoms. So for each of the symptoms, those that have multiple symptoms, for them to have one medication for each symptom in their medicine cupboard actually makes a huge difference. Brings us to this slide, which says that rarely some of the symptoms above may actually be early warning signs for ovarian, colon, or rectal cancer. We always say that any woman, for example, who has bloating symptom should not just assume that bloating is IBS. Any woman who is 50 years and above who has bloating symptoms needs to see a GP to be sure that she's been tested to rule out ovarian, rule out ovarian cancer. Likewise, everything we've said so far could be IBS, but rarely they may be the same symptoms that you find in colon or rectal cancer. And particularly these symptoms here, unintentional weight loss. Some people are working very hard to lose weight, which is fine. But if you have unintentional weight loss, and then your poo is either black or bloody, poo that is black or bloody, if you're taking iron tablets, that can make your poo black. But if you have black or bloody stool, you need to see your doctor as a matter of urgency to have yourself checked. Altered bowel, some people have diarrhea today, they are constipated tomorrow. But if this kind of thing is going on for up to 6 weeks or more, then you need to see your doctor urgently. In fact, if it's more than 3 weeks of constipation or more than 3 weeks of diarrhea, then you need to have your doctors check to make an appointment to see doctors. But if you have altered bowels, 1 week this one, the other week constipation, the other next week diarrhea, and if it goes on for up to 6 weeks, then you need to see your doctor as a matter of urgency. So coming to bowel cancer, then this flash slide is from Cancer Research UK website. There are about 43,000 new cases of bowel cancer every year, which is about 5-6 years ago. This was about 120 new cases of bowel cancer are diagnosed every year in the UK. And deaths from bowel cancer, about 16,800. And the number of people who survive 10 or more years, from the statistics on the screen, just a little bit more than half of the patients survive more than 10 years after being diagnosed with bowel cancer. It's really interesting that more than half of the cases of bowel cancer can be prevented, more than half the cases. And it's been shown from research that many people who have bowel cancer do not have enough fiber in their diet. Too little fiber in the diet is been associated with bowel cancer in more than 1 in 4 cases. Too much eating of red meat or processed meat has also been shown to be a risk factor for bowel cancer. Another thing that we talked about the last time I was with you, talked about living with obesity can also be a risk factor for bowel cancer. And looking at others, so again, lack of exercise, smoking, tobacco, alcohol, age, family history of irritable inflammatory bowel disease like ulcerative colitis or Crohn's, previous bowel cancer can also be risk factors for bowel cancer. And then some people with diabetes, gallstones, acromegaly, there's a tiny fraction of them. These medical conditions can also be risk factors for bowel cancer. People who have had polyps in their bowel, or they've had radiation treatment for any other problem, radiation can be a risk factor, and infection can also be a risk factor. Bowel infection can also be a risk factor for bowel cancer. I mean, this diagram is just to show that, I mean, this is from age 0 to about age 40. There are very few people up to even age 45 who have bowel cancer. So if you can see that the numbers begin to rise from about age 45, 50, but it's still very few people. And then the numbers rise. By the time people get to age 80 and above, of course, yes, I think there are 6 times more people who are 80 years old and above who have bowel cancer than those in their 40s and 50s. Now, this is a dilemma in the sense that, you know, in the NHS where it's free at the point of need, if everybody has concerns that they may have bowel cancer and they all come to us as GPs, we are going to be overwhelmed. But the point is that every individual has to look at himself or herself and then make sure you do what is best for you. So if you have any concerns, read about it. And then, as they say, talk to your doctor. Don't ignore it. Talk to your doctor. Now, the symptoms of bowel cancer, just to reiterate, if you see blood in your poo anytime, it could be hemorrhoids, it could be because the stool is hard, but don't ignore it. If you see blood in your poo, seek advice on that. If the bowel habit has changed, is now loose, is more frequent, or you're constipated for say 3 weeks or more, seek advice for that. By the time you feel a lump in your back passage, that's a bit too late, as it were. But feeling a lump in your back passage or a lump in your tummy, you must get a GP appointment right away. And for such patients, we do a 2-week rule. We make sure that the person is seen in hospital within 2 weeks. So blood in the poo, change in bowels, feeling of a lump. Sometimes when you've opened your bowel, you feel you've not finished opening, and then weight loss. You know, these are all symptoms that may be nothing to worry about, but it may also be bowel cancer. So never, ever ignore them. Another thing I want to mention is sometimes we do blood tests for different things. So if your hemoglobin is low, your blood count is low, your iron level is low, you may feel tired or breathless. Don't ignore those things. Even if your doctor says doesn't look at it as a serious problem, just ask again and then make sure it's repeated, and then make sure when it's repeated it's normal. If it's not normal, is your right to make sure that if it's not normal, you're investigated to find out what the problem is. So if you have any of those things, contact your GP. Now we hear this phrase, contact your GP all the time. And you and I know that the general practice, primary care, every aspect of the health service, even social care, is currently overwhelmed. But as far as you're concerned, if you have those symptoms, don't ignore it. You need to contact your GP. Now, I've put here, contact private GPs. Some of us have access either via our work or via our own insurance to private GPs. We don't use them. So if you can't contact your GP, if you have insurance, if you have access to a private GP, please get in touch with them. There are quite a few of them, which you can access. The other thing is health checks. We have normal health checks at age 40, age 45, age 50 for those who have any long-term conditions, or even if you have. Sometimes during routine health checks, they can pick up that your hemoglobin is low or your iron level is low if that is checked. So if you're offered health check, don't ignore that invitation. When you're offered health checks, please take your health check. The next one is screening. People are invited for bowel cancer screening, I think when they get to age 55 or 60. When you're invited for bowel cancer screening, please don't forget to go for the test, because that's one opportunity. I know quite a few patients who were diagnosed of bowel cancer even before they had symptoms, simply because they went for their bowel screening. And then the NHS app, I think if you've not downloaded the app, download the app. If you have access to your GP records, have a look at your test results. Maybe 3 years ago, 4 years ago, your GP may have done a blood test for you and your hemoglobin may have been low, or your iron level was checked, it was low, and maybe it's been forgotten. So have a look at your GP records, check your HB, check your iron level, and if you are ever low, either send an email or get in touch with your GP to say this was low, what can we do about it? So prepare. If you are going to see your GP, don't just go to the GP and begin to talk about your fungal nail. The GP has 10 minutes for the appointment. So don't just go straight to the point. I saw blood in my poo, or I've been having diarrhea for 4 weeks. Don't bring an irrelevant matter. Just prepare and go straight to the key point that you have. GP will ask you questions and then examine you, and they may offer you a rectal examination, and that's why sometimes male doctors put female patients in general practice. So if you're offered a rectal examination, it's important that you take a rectal examination. The reason is that if somebody has something sinister happening at the rectum, it's only when you put the fingers inside and feel the walls of the back passage or the anal canal that you get to know something is going on there. So if you're offered a rectal examination, please don't decline it, because some other tests that you are sent to do may not pick it up. It may be the rectal examination that will initially pick up a problem there. So I haven't done a general examination, asked about the symptoms. So you prepare for the GP appointment. Check your symptoms, know which ones you have, how long you've had them, how they present, and then when you ask those questions, you have your answers ready. So after the examination, we'll probably do blood tests for you. And the minimum test we'll do will be your full blood count to check your hemoglobin level, do your kidney functions, as well as check your iron level. If you have blood in your poo, or if we are suspecting that you have bowel cancer, we won't need to do that if you already have blood in the poo. But if we are worried about bowel cancer, then we can do a FIT test, which is a stool test, to see if there is possibility of blood in the poo. Depending on your history, the examination, and the findings of the test, the doctor may decide on a 2-week rule, which is an urgent query cancer referral to the hospital. Sometimes after we've listened to your story and done the examination, straight away we do the referral and then do the blood test, so that by the time they see you within 2 weeks, the test results are already out. When you get to the hospital, they will now decide whether they will just put a camera into the back passage and follow it upwards, the bowel. So sigmoidoscopy, colonoscopy, it all depends on how far the camera goes up. And for some people, it's a virtual colonoscopy where they use a CT and then they look at the whole bowel. So these are the things that happen when you have been in touch with your GP. So in summary, IBS, abdominal pain or discomfort, change in the stool frequency or form. The pain or discomfort may be relieved by defecation, For some people, particular foods may trigger the symptoms. And if you have symptoms consistently by a particular food, you can decide to stop taking that particular food and see. When somebody has IBS, examination of the tummy, we don't really find anything. Most times, diagnosis of IBS is from the history. There is no test to make a diagnosis of IBS. We do tests to rule out other problems like irritable bowel, celiac disease, bowel cancer. Worrying symptoms such as feeling tired and your blood count is low, weight loss, feeling feverish, these are not symptoms that you find with IBS. And if you have such symptoms, we have to rule out bowel cancer or irritable bowel syndrome. And treatment should be individualized, which is what we say. Depends on what symptoms you have, then you know what treatment is given. And finally, I would say that if you're concerned, please do not wait for tomorrow. Do not wait for next month or next year. If you have any concern, please seek help. And remember, these are two very important people, young, who have had bowel cancer, and sadly, they've passed away, Chadwick Boseman and Dame Deborah James. So please take these symptoms seriously and look after your health, look after your family. Thank you very much. I'll take any questions or comments. Charles?
Hi, apologies. I'm joining close to the police station. So, Dr. Hector Goma, massive thanks for such insightful presentation. I mean, whilst I'm waiting for questions to come in, I mean, one of the things that struck me from the stats you presented was the fact that 54% of all cases are preventable. I wonder if you could expound on that a bit.
Yes, I mean, for bowel cancer, 54% of the cases are preventable, because if I go back to the risk factors, you can see that many of the risk factors are lifestyle factors. So if we are doing those things right, so when you look at the risk factors, many of them are preventable, things that if we did them, we would not have bowel cancer. And that's why almost more than half are preventable. So something like smoking, tobacco. If you don't smoke, you reduce your risk. People have too little fiber in their diet, more of processed food. If you increase the fiber in your diet, almost a quarter of bowel cancer can be avoided by having plenty of fiber. Red meat, cutting back on red meat. So when you look at these, things like age, family history, you can't do anything about. But alcohol, tobacco, exercise, dietary fiber, red meat, those are things that we can actually make a difference about. So that's why half of it is preventable, is in your hand. And again, obesity, 1 in 10, I think 11%. So if we do these lifestyle things very well, then already 50% of the possibility of having bowel cancer, we've taken it out of the way, which is fantastic.
Wow, thanks very much. And for those of you who are not aware, every Tuesday we have a session on nutrition and physical activity. And it's exactly what Dr. Hector Goma has been talking about, all the preventable stuff, the lifestyle choices. And I like the fact that he talked about we taking charge and not relying on doctors to tell us what to do. So I've got a question here. Will fiber from fruit help, with diet, or would you recommend cereal? I wish Dr. Haber was on as well, but over to you, Dr. Hector.
Okay, well, whoever I like, if there's an additional expert here, I would like them to answer the question. But what I know is that I use the example of oranges. Sometimes people just take the liquid from the orange and they throw away the flesh. I always say the fiber comes from the flesh, so don't throw away the flesh, eat the flesh. But in terms of fiber, isophageal husk or fibogel, as well as Quaker oats or oatmeal is a source of soluble fiber. And then I think anything vegetable, any green vegetable is fine. So for those from Africa, all the ugu and things like that, okra and all of that. So vegetable is fine, but particularly oats and fiber gel are good sources of soluble fiber.
Great, thanks for that, Doc. We've got another question here. Does leaky gut contribute to my condition?
Yes, I mean, when you say leaky gut, I showed a slide. Let me see if I can bring it back. Just one moment, if I can find this slide again. So leaky gut, sometimes, let me just bring this slide. Okay, this slide talks about the things that happen. So if you look at the gut wall, there is a kind of a tight junction between the cells, and then sometimes you have this junction, it's not tight, and you now have things leaking out of it. And then again, the nervous system, the effect of the nervous system can also contribute to that. So the answer is yes. What causes leaky gut sometimes is the symptoms we've talked about: stress, the diet, infections can contribute to leaky gut. Talk about gut microbiota and 4 different ways by which they work. So yes, the leaky gut is caused by factors, and some of those factors are the preventable things that we don't do. And if we do them, then that can help to reduce the leaky gut.
Thanks for that, Doc. So a few more questions come in, which is brilliant. And someone is asking whether extra vitamins will help. And is this something you're going to recommend? Doc, it looks like you've frozen.
Oh, it's okay. I saw you were frozen, so it was from me then. Can you take it again? Take the question again, please.
Yeah, so the question is whether extra vitamins will, could help, and whether you would recommend having extra vitamins.
Well, vitamins are always an interesting thing. The first thing I would say is that if somebody is eating the right foods, plenty of greens in their diets, and you have chicken or fish, if you're eating the right foods, and then your weight is stable, I think that's the first thing I would recommend. High fiber, plenty of vegetables, and all of that in the diet. But having said that, there are micronutrients. I wouldn't say go off and buy plenty of vitamins. Eat the right foods first. Unless you do a blood test, let us say you're anemic, your blood count is low, they do a blood test, and maybe your folic acid, iron, or vitamin D or B12 levels are low, then you can take additional vitamins. So if those vitamins are within normal limits, I wouldn't say go on and take more vitamins, but people who are nutritionists will advise better on all those micronutrients: selenium, magnesium, manganese. I don't have much experience in those ones, but the everyday ones like folic acid, B12, iron, vitamin D, largely, I would say a balanced, healthy diet, plenty of vegetables is what I would recommend first. But otherwise, you can take nutritional supplements.
Great, thanks for that, Doc. And just want to welcome our colleagues from the Seventh-day Adventists. We know that usually Saturdays is Sabbath and you are in church, but good to see quite a number of you. There's a question here from someone whose work pattern is so challenging and asking how or what you could suggest to help them regulate their own lifestyle.
When you say your lifestyle is challenging, well, work-life balance, as it is easier said than done, but that is the key thing there. I mean, when we look at the lifestyle medicine talks about 7 to 8 hours sleep. So if for example, you're a shift worker and you can't do much about it, it means that if you're doing day shift, make sure you sleep well at night. If you're doing night shift, then make sure you sleep well during the day. And the other one is some people, when they're at work, they sit there in front of the computer for 6-7 hours straight. Trying your best to get up for 5 minutes every hour is something that is useful. And then when you're off work, trying to get your 30 minutes of physical activity, those are the kind of things that you would need to do. But obviously, at some time in our life, some of us did 2-3 jobs every day, and later on we're having the effects of all of that. But work-life balance, there is no substitute for trying to balance it by either reducing the work or trying to have more regular hours. All I can say is things like high-density foods. If you're working and you come back late, you get to your house at 10 p.m., don't eat high-density foods, because you eat those foods and you go to bed and you're more likely to gain weight. So food and portion restriction, reducing how much you eat, particularly African high-density foods, when you are coming home late at night, that's the kind of thing that I would recommend. But if you can, I mean, it's the jobs that are 9 to 5 are few and far between. So I guess it's trying to get a balance. Whatever you're doing, think about the ultimate effect on your life, and then making sure that you get adequate sleep, and then have your high levels of vegetables and cutting back on high density African foods in terms of food portion size.
Thanks, Dr. Hector Goma. So just for our colleagues, if you go and visit someone who has been attending health and they don't give you large portion of food, then you know where that's coming from. Right. So and I can see Emeka has his hand up. I'm going to bring him in a minute. But thanks to someone for sharing a story. So his or her brother-in-law passed away at the age of 35 and had initial symptoms that were diagnosed as IBS at 31. So the question from this person is what the system is doing to prevent misdiagnosis.
All right, Oti, I can see your question. I'll just say sympathy on the unfortunate passing away of your brother-in-law at such a young age. I mean, like I showed in one of the slides, that people who are about 80 years old are 6 times more likely to have bowel cancer. And when you look at the UK statistics, you could see that at up to age 45 is quite a few people that have bowel cancer, then it goes up astronomically. And there's always a problem with individual versus population plans. When you look at the number of people, government has a bowel screening program. Somebody will say, why don't you start bowel screening from age 25 or 30? If they did that, my brother-in-law may not have passed. But if you are going to do that kind of bowel screening, it might mean that general practice will come to a stop because of the volume of patients that we'll have to deal with. And that's always the individual requirement versus the population requirement. It is statistics such as the ones I showed you that makes government decide who needs to be seen. And then again, as a GP, I mean, I've been a doctor for over 30-something years and a GP for 15 years or so. I don't know, maybe I've seen 2 to 5 people who are under 40 who have had bowel cancer. And as they say, the common things are the most common. So sometimes it doesn't even occur to us. I could just keep on saying, this is IBS, this is IBS. But like we mentioned, that if somebody has IBS, their weight, for example, is going to be stable. All the blood tests will come back normal. So if somebody has IBS and his HB was, say, 140 last year, is now 130. 130 is still not within normal limit. But the fact that the HB has dropped, the hemoglobin has dropped, should make me wonder, what's going on here. And so I think for us as clinicians is to say, yes, it's more likely to be IBS, but to look out for other symptoms. And then as for patients too, if it is IBS, then remember, if you have new symptoms, for example, blood should never be seen in IBS. All your tests must come back normal in IBS. And if those things change, then you need to go back and insist on having new tests done. Somebody can have a colonoscopy, which is the the litmus, which is the highest level of testing for IBS, is a colonoscopy. And someone can have a normal colonoscopy this year, maybe 4 or 5 years down the line, something has changed. And we can keep saying, we've done colonoscopy for you, it was normal. And that's the kind of situation where somebody can be labeled IBS, but it's something else. So I think the message is know the normal symptoms of IBS. And if you have new symptoms, go back to the doctor and say, 5 years ago, I didn't have weight loss. Now my weight is going down. I had a full blood count. It was normal 2 years ago. Now I'm anemic. Then those are the kind of things that should make us do further investigations.
Thanks for that, Doc. And Oti, condolences once again. Can I bring in Chukwuemeka?
Yes, please. Good evening, Doc. Good evening, moderator. I just have just 2 questions regarding my experience, my health, actually, ever since I've been here in the UK. So let me give this background that, first of all, I have been having hemorrhoid for a very long time. And then in recent times, I discovered that anytime I eat anything, right, I usually have very serious stomach discomfort. I've been having this for some time now, for months now. So I had to approach my GP, complain to the doctor, and then he said they were going to conduct some tests. So they conducted liver function test, kidney function test, blood test, and then I also asked them to include blood sugar level test, which they did. And then the results came out. I was only able to speak with the what I call it, the representative of the GP, of my GP. They told me it all came out normal, and then that was it. There was I couldn't access the doctor to probably give me further explanation on, the results. What do you advise I do in that situation? Because I was expecting to hear, probably hear from the doctor if there are further advice he could give, regarding the situation, even though they say the results are normal, And
okay.
then secondly, I just want to find out, I just want to hear from you, right? Is there a relationship between hemorrhoid, right, and stomach discomfort? Because sometimes I discover that I spend a lot of time in the toilet, using the toilet. I spend a lot of time, and sometimes I actually stool out blood.
Okay. What I would suggest, Chukwuemeka, is that Charles will give you my number and we can have a conversation, because we try not to, in the public sphere, discuss people's health publicly. So I can have a one-to-one conversation. Having said that, one of the risk factors or symptoms of hemorrhoids is constipation. Sometimes people are constipated, and the process of straining to open their bowels leads them to having hemorrhoids. So making sure that is where diet can be linked, so that as long as you're not constipated, that will be an important thing in terms of avoiding hemorrhoids or minimizing the effect of hemorrhoids. But if you get my number, and then we can have a conversation outside this.
Or when can I call you, sir? Are there specific times you wouldn't like to be called?
Just get my number and send me an SMS, then I'll let you know. Yes.
All right, sir. Okay. Thank you so much. You're
welcome.
So Chukwuemeka, I'm putting, you can drop us an email, health@CAHN.org.uk, and then we will pass you Dr. Hector Goma's number. So thanks for that, Doc. A couple more questions. Is inflammation the main cause of IBS, and how can I reduce that?
Like I mentioned, I think I talked about that. I don't know whether you saw the causes. The main cause we don't know, but inflammation it's one of the causes. And in fact, when I was preparing for this presentation, I was saying that all the tests that we do for IBS come back in IBS are normal. And maybe they come back normal because we are not doing the right tests yet, or medicine hasn't advanced to the point where we have the right tests for IBS. So let me just share this slide. Inflammation is actually a factor, particularly infection. I don't know whether you can see this slide, this particular one.
Yes.
If you look at this slide shows different bacteria which are in the gut, lying around the wall, the lining of the gut. Now, in this particular section, you can see that what you see are mainly blue bacteria. On this side, you see mainly red bacteria. Now, these blue bacteria are probably suggested to be protective, but when you have a lot of reds, they lead to leakage of bacteria antigen into, they pass through the lining of the cells, and that now leads to various reactions. And then the inflammation, mast cells, which are here, release the chemicals of inflammation, which now irritate the vagus nerve, and then various things happen. So this is one of the suggested ways by which IBS, and so people who have had a history of infection come down with IBS. So it's one of the mechanisms, but not the only one.
Thanks for that, Doc. I have another question here. Someone is asking, how reliable are the bowel cancer tests that you can buy over the counter?
I know that, with the advent of genomics in the last 20 or more years, a lot of tests are now in the market. So it all depends on what that particular test is. My advice really is the tests that you can rely on are the FIT test, which looks for blood in the poo, the FIT test. So if it's the FIT test, if they say there's blood in the poo, then you'll be referred for camera tests into the intestine. So FIT test is, I would say, is the most reliable test outside of hospital. And then hemoglobin and iron levels are the next. So there are various genetic testing that is being done. I don't have much knowledge about which one to advise on, but FIT test is the first test that we use for bowel cancer.
Brilliant. So I have another 2 more questions, and I'll bring in Dr. Ambrose. Would unmute him so he could ask this question. So someone is asking, I have endometriosis and I appear to have many of the common IBS symptoms you describe. Could there be a possible link?
Yes, in the sense that IBS, like bloating, is a feature of IBS. I remember I've said some time ago that ovarian problems would feature similar to IBS symptoms. So particularly in the woman who is 50 years and above, don't assume it's IBS, get tested. I think with endometriosis, the menstrual cycle has an impact on the kind of symptoms that people have. And people who have IBS, some people who have psychological aspects of IBS, even the menstrual period may be times when they're irritable. And when they're irritable, they're more likely to have IBS symptoms. And when people have endometriosis, around the menstrual period, they may have more of the symptoms. So the answer is yes. And then inflammation, is one of the symptoms of IBS. And the inflammatory process can also be there because of the endometriomas, which are outside the womb itself. So the answer is yes, that the symptoms are about the same: abdominal pain, abdominal discomfort, bloating, constipation. These are symptoms that you may also find in endometriosis. But it's always important not to assume it's IBS, but to do various tests, which will now rule out other conditions.
Okay, thanks, Doc. I'll bring in Dr. Ambrose, and then someone is asking about the vitamins you mentioned. Which vitamins would you encourage? So
Hi, Hector. Can you hear me?
Yes, I can hear you, Ambrose. How are you doing?
Hello. My question is, many often than not, we see patients getting confused about IBS and ulcerative colitis, And as soon as they're called to hospital, I remember when I used to work in liaison psychiatry, they will be scared that they have got cancer. So can you help us understand how IBS and ulcerative colitis present and whether they can lead to developing cancer, please? Thank you.
Okay. I mentioned, I think one of the slides I talked about other things that people with a family history of inflammatory bowel disease. Two key things that differentiate IBS from UC, ulcerative colitis, is that one is inflammation of the bowel leads to leakage of blood. So people that have ulcerative colitis, most times may have blood or mucus in their poo. You never find mucus in IBS. There is no blood at all. You don't find blood in IBS. So any blood in the in the poo, you don't find it in IBS, and that's more likely to be ulcerative colitis or Crohn's disease. And one of the blood tests that we do is CRP, which is the inflammatory marker. The inflammatory marker is always negative in IBS unless there's an infection at the time. Inflammatory marker is almost always raised in ulcerative colitis. And the final one is that we talk about FIT test. If no, there's another test, fecal calprotectin is a new test which we have, which helps to separate or differentiate inflammatory bowel disease from IBS. So if people have IBS symptoms and you're wondering, could this be ulcerative colitis, we do a fecal calprotectin stool test. And many times that stool test is over 200, and then we just refer them to gastroenterology. So those are the two ways by which one is the blood in the poo, and then two is either CRP or fecal calprotectin tests are positive in those who don't have IBS.
And can they lead to cancer?
Well, inflammatory bowel disease is a risk factor for cancer, but what percentage of people with inflammatory bowel disease have come down with cancer? I don't know. But when you look at those risk factors I put, you could see the numbers, the percentages that we had, percentage for low fiber, for lack of exercise, inflammatory bowel disease, yes, is a risk factor, but I don't know if it's 1% or less. I'm not sure of the actual likelihood of having bowel cancer from IBD.
Great, thanks for that, Doc. So a couple more questions. So I ask for permission to give us a few more minutes. So someone is asking about vitamins, and then another person is asking what are the high density African foods to avoid before bedtime. And I think, our comms manager Ngozi has agreed to speak to Dr. Hiba. So that next Tuesday we look at the high fiber foods and all that. But vitamins, what are those high density African foods?
Okay, vitamins, I always like to give answers based on facts. And there are people, particularly in America, even more here, and there are people who live on vitamins from various companies, and I have nothing against them. But I would always say the first thing is a balanced diet, which is rich in vegetables, natural vegetables, whatever African and Caribbean greens that you have. You can never have too much of vegetables. Your body will not absorb them. So that's the first thing. And then haven't had very good greens in our diets. The next thing is that because of the color of our skin, I think we are more likely to have vitamin D deficiency in this part of the world. So making sure that you have vitamin D supplement, particularly autumn and winter seasons, is something that I would recommend. So if you're taking 1,000 units of vitamin D during autumn and winter season, that is fine. But for the rest of the vitamins, like B12, folic acid, vitamin A, all those ones, if you're having a diet that is rich in vegetables, I won't recommend it. But if you're picky about your vegetables, then you can get one of those vitamins, whatever, get a container and take one more one pill every day to give you additional vitamins. So my take on it is healthy diet full of vegetables. If you can't do that, then just get a multivitamin and take one daily.
Great. High fiber foods.
Yes, I mentioned, high fiber food. I know, like somebody mentioned, a lot of African foods have high fiber, but in terms of high density foods, I think it's those of us who are Christians, as they believe that, somebody was told, eat, kill, and eat, and they said they won't eat. And if every food is good, so there is no food that I would say don't eat. Every food is good, but do everything in moderation. The healthy plate, I like the healthy plate model. I don't know, many of us Africans and African Caribbeans may be against the healthy plate model. The healthy plate model says that you might picture your plate of food, divide it in two. Half of the plate should be green vegetables. Whatever you're eating, half of the plate should be green vegetables. Then the other half divided in two. 1/4 should be your fufu, rice, yam, whatever that white food is, should be 1/4 of your plate. And then meat, fish, chicken, whatever it is, should be the other quarter. So when you put your plate like that, and you imagine the mound of Okonkwo's celebration and things fall apart that most of us eat, that's why we have health challenges. So divide your plate into half, into two. Half should be vegetables, 1/4 white food or starch, 1/4 should be meat, and you can never be wrong at that point. If you come back home at 10 p.m., imagine that when you eat, you should utilize the food. When you come back home and you're going to bed, you're going to use the food to breathe, maybe to snore. You don't need that much energy. So there's no point loading yourself when you're just going to use it to sleep. So that's the point. If you eat and you're going out, that's fine. But if you eat and you're going to sleep, you don't need much energy to sleep. So cut back, really take small portion. If you want to avoid diabetes, if you want to avoid colon cancer, if you want to avoid spare tire, for those who are from Nigeria, who are here, if you want to avoid being overweight, then really cut back on your food size, more so if you're eating at night.
Thanks, Doc. I'm going to try one of these days, have salad and fufu at the same time. 2 more questions and then we can wrap up. One is, can diverticulitis disease be linked to IBS? And the second one, back to food. So I'm encouraging most of you, if you can join us 5:30 next week, or no, 6 o'clock next Tuesday for the Healthy Heart. And another question is, what type of food can trigger IBS? And what's the difference between, okay, I think we've answered that already, but what type of food can trigger IBS?
Okay, the question first about IBS and diverticulitis. Diverticulitis comes from diverticulosis, which are outpouchings of the large intestines. There are some pouches, it's kind of, if that's the intestine, then you have a small pouch. So the food that is coming down, bits of it goes in there. And if that happens, that's diverticulosis, which just causes kind of abdominal discomfort. But when that pouch area becomes inflamed, then that's diverticulitis. So constipation is the #1 cause of diverticulosis. And constipation is one of the 4 main symptoms of IBS. So if somebody has IBS-C, which is a constipation predominant IBS, and they don't manage that constipation, that could make them to be predisposed to diverticulosis. So managing the IBS and preventing or promptly treating constipation will also help to reduce the likelihood of diverticulitis. And diverticulitis occurs because the food, you don't have bulk, your fiber is less, so you don't have bulk feces coming down, and some of it goes into the pouches. So preventing and managing constipation prevents or manages diverticulosis. That's where there's a link between IBS and diverticulitis. Poor management of constipation predominant IBS can make somebody who has diverticular disease end up with inflamed diverticulosis, which is diverticulitis. So that's preventing constipation, managing it promptly is just the link between the 2 conditions. In terms of what types of food, one of the things that is happening is this issue about the gut microbiota, the bacteria in the gut, they work on carbohydrates. And when they work on carbohydrates, sometimes the things that are produced now irritates the lining of the bowel and causes bloating and some of those symptoms. And that's where the first thing is actually a food diary, which is just maybe for 1 or 2 weeks, everything you eat, you make a note of it. If you eat something and you have bloating, pain, constipation, or diarrhea, you make a note of it. And if there's any food which every time you eat it, you have symptoms, then you can just say, let me avoid that food and see what happens. And if you avoid that food and you don't have the symptoms, you don't even need to see a doctor for that. So there are some foods, the high carbohydrate foods in some people are linked to IBS. But for some people, it might not even be the food. Imagine I'm stressed today. I go and buy pizza because I'm stressed. When I eat the pizza, I get bloated. I associate the bloating with the pizza, but it might be the stress from my boss at home or my boss at work, which has caused me to become, the stress is what has caused the bloating, but I associate it with the food. And that's where it's good to keep a food diary. So at the end of the day, no particular food, but high carbohydrate foods in some people can be what causes them to have IBS symptoms. That's why the FODMAP diet is about taking away the high carbohydrate food and then bringing it back, slowly. That's what the dietitians do with patients. And the final one is types of African foods. All foods are good, I said. So there's nothing that is good or that is bad. It's just how much of it you take that makes all the difference.
Great. Thanks very much, Dr. Hector Goma. So whilst we are about to take final remarks from Dr. Hector Goma, can you tell us how you found the session? And we want to hear from you. What are some of the topics you want us to cover predominantly on the Saturday mornings? Coming Saturday, the focus is on menopause. And, you might have a brother, you might have an auntie, a sister, please, we want to see as many men as possible because we need to help our women as they go through that. So, any final closing remarks from you, Dr. Hector Goma, and then a couple of announcements. But Saturday morning, it will be the same Zoom ID, 11 o'clock, and the focus will be on menopause. Over to you, Dr. Hector Goma.
Well, fine.
I think, Doc, you've frozen. So whilst we wait for Doc to come back in, Saturday, we're going to have Dr. Patrizata looking at menopause. And we know for some people it's a taboo subject. But then a couple of other events from CAHN and our partners. There will be the launch event for Black History Month for those of you who live in or around Greater Manchester on the 28th of September. But also a date to save is the 22nd of October for our Black History Month Gala at Deansgate, Hilton. So is Dr. Goma still with us? Well, I just want to encourage you all, please, lifestyle choices. All the doctors who come on keep hammering on that. So Tuesdays are healthy heart, nutrition and physical activity, and you can never go wrong. Stick to the healthy plate. Yes, you may want to try some fufu or eba and salad at the same time, but we do have support available if you want to speak to someone as well. We do run a Black-led counseling service. So if you need any support as a result of any emotional needs or bereavement, then feel free to reach out. But massive shout out to our partners, RAFA, International Development Agency, Croydon BME Forum, Enfield Caribbean Association, Black Health Initiative in Leeds, and then the RCCG Royal House in Sheffield for promoting and sharing this with our partners. So if you need to have any private consultation, drop us a line, health@CAHN.org.uk, or text, WhatsApp message, phone our helpline 077 100 22 382. So a massive thanks to Dr. Hector Goma. IT challenges, but I'm sure you've enjoyed the session. This has been live streamed, so it will be on our YouTube and Facebook channel. So search for the Caribbean African Health Network and you can watch it again and share. Okay, Dr. Hector is back. It's always good to get, the final closing word. So over to you, Dr. Hector Goma. Yes, we can hear you.
Well, apologies, but I think I finished just on time. So sorry about that. So just know the normal symptoms, deal with them, but particularly the older patients, if you have concerns, have a GP appointment, have your relevant tests, and know what to do. Get referred if need be. Particularly blood in the pool, don't ignore it. Blood in the pool is this weight loss, blood in the pool, and then having low blood count from any previous test. Don't ignore them. Have yourselves checked out by your doctors.
Good. Many thanks. Massive thanks once again, Dr. Hector Goma. You've had a busy day, but it's great to see you and to have done such insightful presentation. And someone has requested that we do a bit of men's health. It will be good to see yourselves. I think Dr. Hector Goma did prostate cancer, if I'm right. So once again, if you miss any session, always on our YouTube, but Silas will take your email address and we will be in touch. We will try and do a bit more focus on men's health as well. So massive thanks, everyone. Have a good evening and make sure you don't have a heavy meal, especially the African one before you go to bed, and start having the salad and, alongside the eba and the egusi and the others. Have a wonderful. Over to the comms team for the outro.
Our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.